I would like to thank the organizing committee for the kind invitation to participate today with my topic, which is radiomics in breast cancer, and my focus will be on breast MRI, the recent advances and the emerging clinical value. So the outline of my speech includes why radiomics is important, and this is closely linked to the associated terminology and definitions of the use of AI tools. Then I will move on to how to perform radiomics very briefly, which is a four-step process that includes image segmentation, image processing, feature extraction, and data analysis. And then I will move on to the heterogeneity of tumors, which is actually, in my opinion, the driving force behind the development of radiomics. And the main body of my speech will be the emerging clinical applications, and I will focus on texture analysis, the entropy maps, peritumoral radiomics, and a new biomarker, which is the vessel tortuosity marker, with a few brief conclusive remarks. So the goal of oncologic medicine is to design tailored treatments for each patient. But the big obstacle is that there are countless variables that include tumor demographic and treatment characteristics. And one way that we could diminish the effect of these variables is to better characterize the initial tumor. And the way to do this is with radiomics. So looking at the statistics for cancer incidence and mortality rates in the European Union in 2020, we see that about 46% of the women will at some point in their lives be diagnosed with a cancer. And breast cancer accounts for 29% of all these cases. On the other hand, we see that the mortality rate is much lower, and this is due to several reasons. Firstly, not all cancers are lethal. And also, early diagnosis and screening has led to decreased mortality rates. And also, there has been a significant progress in the cancer therapies. So all these are factors that contribute to the decreased mortality rate. So to really address the issue of precision medicine, we need to be aware, and we need to fully comprehend these radiology AI tool definitions. So diagnostic tools refers to accurately identifying the presence and the type of disease. Prognostic tools refer to predicting disease outcome. And predictive tools means that we can correctly predict response to treatment, which is what the oncologists are basically interested in. Now, both prognostic and predictive tools help us move away from the one-size-fits-all to tailored treatment and outcome for each patient. Radiomics means that we have a group of features that are extracted from a large number of quantitative parameters in our images that are sitting in our PACS machine, and they are converted to mineable data without a prior hypothesis. And in sequence, it begins with imaging the patient, and the pipeline of radiomics begins with segmentation, where we segment a region of interest, in this case, the breast tumor, and we move on to feature extraction, and we do data analysis that will assist us in correct treatment planning and more information with regards to the prognosis of the patient. So now we'll move on to how to actually perform radiomics very briefly. The first step is the step of segmentation. Now, what we do is we segment the entire tumor, and this can be done in various ways. We can do manual segmentation or in an automated or semi-automated fashion. Now, we prefer to do it in an automated manner so that we can include the entire tumor. It is performed in a 3D fashion, so we can include all the tumor extensions and the speculations at the edges of the tumor. In manual segmentation, we still have this slice-to-slice effect, and we generally tend to miss out small parts of the tumor. So we really want to do it in an automated way. And also, automation is very important for reproducibility, which is very important for radiomics. Now, there's a very important in-between step between segmenting and feature extraction, and this is the image processing step. And this step is important because we want to normalize and standardize our data, because there's a lot of technical and other factors that are involved in the acquisition of this data. These are factors that have to do with our sequences, our MRI units, and many others. Another way we can do this is by resampling our data so that pixel spacing becomes more comparable, or discretization so that we can have fewer gray levels and less noise in our images. And we load this all onto a Python parameter file, which has different parameters for our CT and our MR images. But generally, you need to have a knowledge in programming to do this step. Now, the third step is feature extraction. We can extract a lot of features in this step. These features have to do with the size and shape. They can be histogram features, but the big bulk of features in MRI has to do with texture, where we see the differences and the similarities between adjacent voxels, and we can draw maps from these. In feature extraction, we generally get a lot of features, in the hundreds and more often in the thousands. Now, a lot of them are very redundant, but there are a couple of useful features in every feature extraction step. And the fourth step is feature reduction and data analysis. Now, as I mentioned before, the range of features is between hundreds or usually a couple of thousands. And the problem is that usually our number of patients in radiomics studies is small. And in most studies, it's actually less than 100. So we have the problem of overfitting. That means we have too many parameters for the number of patients. So that means we come up with a lot of irrelevant conclusions. So feature reduction is very important. And moving on to the heterogeneity of tumors. So the challenge of histological diagnosis of tumors is that sampling occurs only in a very small segment of each tumor. And we know that the aggressiveness and the worst prognosis of a cancer is associated with tumor heterogeneity and subclonality, which may be either underrepresented or less commonly overexpressed according to the small area of biopsy. And it is a well-known fact that intertumoral heterogeneity is captured with imaging, and that is something that is not possible in histological sampling. Even though I should say right now we also have the development of pathomics, and that is becoming less of an issue. Now, the problem is that tumor clonality changes during the course of therapy. And tumor response may be observed during therapy. And if the clones change, several clones might develop. And even though we have initially we might have a response in the tumor, this may, in the end, where we measure our RECIST criteria, this may lead to progressive disease. And I'd like to show an example on the right-hand side. This is a MIP image of a breast MRI. We have a large tumor that occupies the bigger part of the left breast. Initially, this tumor shrunk to a great degree. During the course of the therapy, though, we had small tumor clones that seemed to be increasing in size. And this is preoperatively where the tumor again ballooned. So tumor aggressiveness will not be accurately assessed unless the heterogeneity of the tumor has been captured. And the way to do this is through radiomics. So this brings us back to the fact that there's a lot of subvisual information in images that is not being used by radiologists. And the goal is to create predictors regarding tumor aggressiveness and patient outcome. And the way to do this is to extract knowledge that is already embedded in our images. And knowledge extraction happens when we extract features and we do data analysis on our images. So moving on to the main part of the talk, the clinical applications. Now, 2 words about breast MRI. We know that tumors display neoangiogenesis and increased vessel permeability. So we obtain images over time after the injection of contrast medium, which leads to increased signal of the tumor. So here we have a pre-contrast image. In the middle, we have a post-contrast image. And on the right, we have a subtraction image where we can see the tumor in the center of the left breast that is highlighted. And also, we continue to image after contrast injection, so we can have a 4D image analysis, which means that we can track the uptake of contrast, and a steep uptake with a steep washout is very specific for breast tumors. So in doing this, the radiologist can indicate the region of interest, which means the center of the tumor. As we said, we segment preferably in an automated way, and here we have an example of a segmented tumor post-contrast. And then we can extract several features with a special emphasis on texture features. Now, texture analysis refers to a variety of techniques that quantify the spatial complexity or the heterogeneity of tissue gray level patterns. And this may range from simple histogram features where we tabulate the frequency of the gray levels and we can compute basic histogram statistics. But we cannot show interpixel relationships. To do this, we need high-order gray-level statistics and spectral properties that are not visible to the human eye. So to assess interpixel gray-level relationships, we need more complex textural features, and we can construct gray-level co-occurrence matrices, for example, and run-length matrices. Now, gray-level co-occurrence matrices are constructed by systematically considering the relationship between pixel pairs. And in that way, we tabulate the frequency of the different gray-level pairings within an image. And this is an example of a 3x3 guide. We identify the reference pixel with the gray level I, and we count the number of neighboring pixels. So we have 0, 0, 0, 1, 0, 2, and tabulating this here we have, for example, 4, 0, 0 pixels, neighboring pixels, 2, 0, 1 pixels, and in this way we can complete the gray level co-occurrence matrix. And this was the idea behind 2 studies that we did in collaboration with Dr. Papanikolaou at the Champalimau Institute in Portugal, and that was presented at the USOBI meeting of 2018. So the purpose was to develop a radiomic signature that could predict the molecular subtype of breast cancer. And we had a cohort of 30 patients. 19 patients were luminal patients A or B, and 11 were HER2 positive patients. Now, the radiologists segmented the lesions in the early post-contrast images, and texture analysis was performed using the PyRadiomics library. Now, as a result, we obtained 2,150 radiomic features. As I mentioned before, we get a lot of features in the thousands usually, but after the univariate analysis, 22 radiomic features could specifically differentiate the luminal type tumors from the HER2 tumors, and after multivariate analysis, 3 features survived. Now, the maximum area under the curve was 0.87, which was considered relatively good. So a radiomic signature extracted from the early post-contrast MR images, where we see most breast cancers, could non-invasively differentiate the luminal type from the HER2 molecular subtypes. But of course, these results need validation with larger studies. And in our second study, we attempted to develop radiomic signatures that could predict tumor grade of breast cancer. Our cohort consisted of 33 patients with biopsy-proven malignant lesions. 16 were low-grade and 17 were high-grade. Again, texture analysis was performed using the PyRadiomics library. And as a result, again, we acquired 2,150 radiomic features, where in the univariate analysis, 66 features could differentiate between the low-grade and the high-grade tumors. And in the multivariate analysis, 3 features could be used. There was a slightly lower area under the curve, maximum 0.82, but again, a radiomic signature from the early post-contrast images was capable of differentiating non-invasively the low-grade from the high-grade tumors. Another very exciting radiomics descriptor is the Coliage entropy maps. Now, we know that the predominant angle of the pixel is determined by its surrounding pixel, which gives us the pixel angle that is specific for each pixel. Right here. So applying entropy maps to these angles, we get low entropy areas, which are determined in blue, and high entropy areas that are represented in red. Now, the thing is, with entropy maps, we can obtain them from all our routine images, not only from our contrast enhanced, but also from the T1 and the T2 weighted images. And the authors of this article that was that was published in Scientific Reports shows that entropy maps reveal subtle microarchitectural differences. So the amount and the distribution of entropy is capable of distinguishing between the different molecular subtypes. And also we know that sometimes benign and malignant phenotypes may appear similar on anatomic imaging, but they will definitely differ in their entropy patterns, and this offers significant diagnostic value for these cases as well. Now, this was presented at one of the previous ASCO meetings, where the authors showed that entropy may be used to identify the molecular subtypes of the HER2 tumors, both the enriched and non-enriched tumors that do not respond to Herceptin. In other words, they did a type of subtyping. And they found that elevated Coliage entropy is observed in pathologic complete response, and it is associated with the presence of tumor-associated lymphocytes. You can see it right here. Whereas the heterogeneity of Coliage entropy in non-responders was due to a combination of tumor cells, necrosis, and sclerosis. I don't know if you can see this here, but there is a lot of heterogeneity in the non-responders intratumorally. So that means non-responders may be identified at an earlier stage, and they may be quite early directed towards other therapies. They won't need to go through the whole therapy and then realize that they are non-responders. And another exciting thing is that there seems to be a strong association between the radiomic entropy features outside the tumor, or actually in the periphery of the tumor, and response to chemotherapy. So patients with pathologic complete response displayed low peritumoral expression of the Coliage entropy features, and these peritumoral entropy features are increased among non-responders. So there's a significant predictive and prognostic role in peritumoral radiomics with regards to response in neoadjuvant therapy. And the question, of course, is why? Because when we observe a radiomic signature that seems to be working, we have to always explain why it is working. Now, tumor-associated lymphocytes are significantly associated with pathologic complete response. And it seems that the peritumoral entropy features are strongly associated with the density and the arrangement of these lymphocytes that enable non-invasive subtyping of the HER2 breast cancers into the responders and the non-responders. And this is one of the latest radiomic biomarkers. It's called the Van Gogh marker. It's a vessel tortuosity marker. Now, we know that differences in morphology of tumor vascularity in non-pathologic complete response versus pathologic complete response patients are distinguished by twisted and angular vessels, and there's also reduced vessel function, such as slow uptake in the vessels near the tumor, which means that the therapy doesn't effectively reach the tumor in the non-responders. So tortuosity of the tumor vessels was converted into the first tumor vessel radiomics marker, and that may potentially assist in predicting treatment response. So to conclude, I would like to say that there is an increasing role in precision medicine for new emerging radiomic biomarkers such as intratumoral and peritumoral textural features, entropy features, and vessel tortuosity, tumor vessel tortuosity. But what we need are large, deeply annotated data sets from multiple sites for study validation and for testing the performance of radiomics in patients, because we said that there are a lot of technical factors that are influencing the effect of these radiomic signatures. And of course, correlating radiomics with pathomics and genomics is important to create accurate predictors of response and progress. And lastly, and for me most importantly, radiomics will be used to personalize cancer treatment, and this will not require additional imaging, just AI tools to analyze the images and the hidden information of our patients that already exist in our PACS machines, and this will revolutionize cancer treatment. Thank you very much.
Thank you very much, Dr. Panουργιά, dear Eva. This was an excellent lecture on a very important topic of practically imaging biomarkers. Radiomics is one of our great tools on that, on MRI, and it's true that tumor heterogeneity is very well captured by radiomics, and this could be helpful for us not only on guiding our interventional procedures, but also, as you very well underlined, evaluating response to treatment. This is really a huge topic of interest for us, of research for neoadjuvant chemotherapy, which is of more and more clinical utility, even in cancers that previously were not candidates for that. So thank you for nicely resuming all these informations. And I have only one question to address to you. Radiomics inside the breast parenchyma, we know, okay, we're working on that, we get more and more information, we are pretty much happy with the evolution. How about the axilla? I mean, there's a huge, and I'm glad to have breast surgeons with us. Axilla is still a huge debate. How should we proceed? We have the Z0011 results that have revolutionized the way that surgeons deal with the axilla. We have the upcoming results of the Sound trial, where they say that we might even not operate the axilla at all in specific cases. So how radiomics can help us on that, and if there are any studies or developments or your personal experience on that?
Okay, I think generally non-invasive imaging in the axilla is actually the nemesis of imaging. We cannot accurately assess the axilla. And there have been several studies done with regards to radiomics and the axilla. Now, there is growing evidence that it will be effective, but we are not quite there yet. I think one of the recent publications in Insights Imaging this year determined after a meta-analysis that we still, even after radiomics, lose about 1 in 5 patients that do have metastasis in the axillary lymph nodes. So it is progressing, but we're still not quite there yet.
Okay, thank you.